All right. One of the things I thought very interesting about this assessment was going into it, I really thought that communication would be the #1 problem, right? A radiologist made the diagnosis and was accurate, but just failed to communicate it in whatever way. We're always told that's make that call or you'll get sued. And so I had conflated those two things and thought that was definitely going to be the biggest problem we faced. So if you look down the columns for SOC towards the right and COMS, right? SOC is the standard of care. Was the standard of care met? So in every one of those where there's a green plus sign, the radiologist made an accurate diagnosis and put that in the report. The standard of care was met. But then in the next column, communications. Was communications an issue, right? That's what I wanted to look at. And so here's how those 10 cases where the standard of care was met broke out. The top 5 are cases in which communications were in fact an issue in some way or other. The bottom 5, the standard of care was met, the findings were communicated appropriately, and something else led to an indemnity being issued. That something else basically boils down to one of two things. First, it can be political, in which there are multiple people named, right? As you can see, our apportioned liability varies significantly, and that usually is based on how many other people are named, right? So was the ER doctor named? Was the managing family practitioner named? Were other subspecialists named? So that can make a big difference. And what happens is people will start settling out of these cases. And all the medical malpractice lawyers are particularly paranoid about being, as they say, the last guy at the table, right? So when people start settling out, what a lot of legal teams will ultimately advise you to do is just get out, right? Because your apportioned liability is going up with each person that exits the case. The other thing I noticed, and again, we're talking about these bottom 5 where the radiologist did nothing wrong. The other thing I've noticed about those, at least 2 of those cases were cases with an unfortunate outcome in a patient who had no ability whatsoever to pay. And clearly the system is geared to just pay them. Somebody's got to pay these bills. This person is still alive and has a high cost of care. And a lot of times people just say, look, somebody's got to pay it and it's going to be you guys, right? Cost of doing business, unfortunately. Okay, so now let's look at the top 5 though, where communications were an issue. So when I talk about communications being an issue, typically what I'm thinking is, hey, you put the finding in your report, you just failed to call the clinician to alert them to its presence. Right? That is what I assumed. How many times out of those 5 was that actually the case? 2. So this is out of a total of 45 cases. There were only 2 where the primary failure was accurate diagnosis, failure to communicate. And they were both cases of acute pneumonia on a chest x-ray. And so the medical directors are probably reliving this now, but we had this whole discussion. I said, that's got to go on our critical findings list, right? It's got to be a required. If you know that you are diagnosing a new diagnosis of pneumonia in an ambulatory patient, not previously diagnosed, right? I'm not talking about the confusing atelectasis issue of the left lower lobe on ICU patients. I'm talking about ER or urgent care case with acute pneumonia or findings consistent with it, you need to call it, right? And this, it causes an uproar wherever I talk about it. But what about all I can tell you is I'm in possession of this information and I don't feel right about not sharing it with you, all right? So make of it what you will. But when you see an acute pneumonia and you know you're the first person making that diagnosis, you need to call it in. The other ones were just curious errors. One was we called it, the clinician refused the call, said, I know it's appendicitis. Well, the second line in that impression was, renal mass consistent with renal cell carcinoma. That clinician did not read that case, did not read that report, and obviously disaster ensued. The cord injury case was kind of interesting. This was a mentally disabled 19-year-old patient who had a tendency to wander from his institution. And so he had wandered out into the forests of Arkansas. They noticed he was gone. They went out looking for him with dogs and flashlights, and they found him and they tackled him. And he had one of those kind of distraction injuries of his cervical spine, and it was read appropriately. It said, you know, soft tissue evaluation's not perfect, but this is suspicious for an underlying cord injury or nerve root avulsion, and I recommend an MRI. He called it in, and the on-site clinician, I can just picture the conversation in my head. The on-site clinician said, oh, I can't get a good exam on this guy. He's not telling me a good history. Can't you say it's old? And so an addendum was issued that said, you know, clinical correlation recommended, changes, acuity of the changes are uncertain, et cetera. And I always remember one of the lawyers said, hey, without that addendum, you guys aren't even in the room. So we were kind of browbeaten into that one. And then the last one, the stroke, unbelievable. It's the only voice recognition error we had in this whole collection. But you guys may know one of our favorite initiation, macro initiation words is click. And the radiologist said, click medical. And I assume that was a macro to say, you know, medical correlation or something like that is recommended. The on-site physician read that and it came out as clip medical. So the on-site ER doctor says, oh, well, there must be a clip in the brain, and therefore this patient can't get an MRI. So that was appropriately ridiculed by some of the legal counsel and said that's really a ridiculous interpretation of that report. So those were the 5 where communications were an issue. And again, the only 2 where there really was a diagnosis made and no call made, and in both cases, the patients were seen in urgent care. They were discharged without the referring clinicians, the treating clinicians reading the reports, and they both came back septic and had horrible prolonged ICU stays that resulted in multi-million-dollar settlements. And they were the ones that bumped the average indemnity on chest x-ray, in fact. All right, so those are the 10. So we have 45 cases. There were 10 that were not specifically related to a diagnostic error, right? 5 where communications were the problem, 5 where it was politics or extenuating circumstances. So that leaves us with 35 cases of diagnostic error. So these are the ones we're going to look at for the next couple hours. Couple hours, yes, there are 35 cases here. So the way they trend, though, is noteworthy, because I've done this now, a basic assessment for the RAD partners data as well. They don't have as consolidated a data as we do, but the trends are very clear. So I'll share those first, we'll take a break, and then we'll go through the cases. Spinal epidural abscess, aortic dissection, and ischemic bowel of a variety of causes. Those are the clear trends, and together they made up $18 million out of the $44 million that we paid in total indemnities and legal costs for this entire collection. So it basically comes out to about 40%. So about 40% of all the expenditure we made on diagnostic error medical malpractice cases were one of those 3 pathologies: spinal epidural, aortic dissection, and ischemic bowel. So we will go through those. The one last thing I'd like to point out is our educational content, and as I'm sure the vRad folks know, our AI algorithms. We are running AI algorithms. We have built them over the last 8 or 9 years at this point. And we have developed AI algorithms that are running and providing you with a safety net And we ran them actually all through 2022. And I have a lot of data that I'm still going through, but it basically, to date, it shows that we have about halved the missed spinal epidural abscesses, aortic dissections, and ischemic valve. And I think it's important to note, we have QA data, we have med-mal data, and we use that data to determine the content of our educational programs and the specific AI algorithms that we build to gird the efforts of the practice. Right? So this is another one of Ed Calloway's footprints at vRad. He created our classification system and goes through our several thousand major misses per year. A reminder, we read 6.5 million a year. And he categorizes them according to anatomy and to pathology. And so we can look at this chart and see, what do radiologists really miss? And the two big categories, fracture and nodule mass adenopathy. Those are the big ones. Now, those are large categories, right? But those are undoubtedly far and away the most common types of misses. But there are a couple specific ones on here that are worth noting, and those are intracranial hemorrhage and pulmonary embolism. So if you take the data that I just gave you, the most common med-mals are spinal epidural abscess, aortic dissection, ischemic valve. The most common QAs, or missed findings according to our QA data, are PE and intracranial hemorrhage. And what that has resulted in are 5 algorithms that we run on all relevant studies for aortic dissection, spinal epidural abscess, PE, ICH, and superior mesenteric artery occlusion. So what I did is, I won't bore you with all the math, but I went through and I found the numbers on all of these. How many QAs did we have on each of these? How many cases were detected by AI? How many medical malpractice cases did we have? And lastly, using our natural language processing, we can go through our archives of reports and find the number of actual diagnoses of any of these entities, right? So that's what that bottom row is. That's how many the natural language processing detected in our reports, right? And you know, of course, that's the important difference between NLP and, say, word search in a Word document, right, is that NLP is contextual. If you search all our reports for appendicitis, you're going to get garbage, right? No evidence of appendicitis, can exclude appendicitis, etc. NLP will go in and say, this is describing an aortic dissection or what have you. So we actually have a good idea of what the real incidence of these pathologies are. And I went through and did all the math and put these all over 1 million relevant studies. So there are the totals, and out of any given 1 million relevant studies, that is the prevalence of each of these pathologies that we expect to see. So that's how frequent they are. Now we can go from there and come up with, what is the total miss rate, the absolute number of misses per million studies? What is the standard miss rate, which is when a finding is present, what are the odds that the radiologist will miss it? How many missed cases then convert to a medical malpractice case? That's the med-mal conversion rate. Then we can calculate the average indemnity for these from our med-mal data and come up with a dollars per million studies saved, and based on our study volumes, the dollars per year saved. And what that comes down to is actually $4.7 million annually if we had perfect sensitivity in our algorithms, which we don't. It looks to me like we're finding about half of all of them right now. So our AI algorithms in 2022 most likely saved us about $2.5 million. And that's just in med-mal payouts alone, not to mention all the improved patient outcomes. All right, so now you know where we're going. We'll take a 15-minute break and we'll come back and look at all the cases of spinal epidural abscess, aortic dissection, and ischemic valve.